Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz podcast will surely satisfy your podcast fix.
Hello and welcome to another exciting episode of the Fuller Butz podcast. I'm one of your hosts, Dr. Sam Fuller, and with me as always is Dr. Dan Butz. Dr. Butz, how are you enjoying the dog days of plastic surgery, the dog days of winter? Any exciting howling news from your family as far as these dog days that you're dealing with?
Our new dog, you really led me into that one. I got a new puppy about 4 weeks ago. He's been a lot to add to the chaos we already have in our lives, but he's quite the joy, and we're kind of quickly learning to have him part of the family. So it's been a big change, but a lot of fun.
So tell me about the specs. How many cc's is the dog? Is it hyper-ejection? Like, what are we talking about? What kind of dog is it?
It's a Cavapoo, a King Cavalier mixed with some sort of golden doodle. He'll be about 30 to 35 pounds when he's fully grown. Currently he's about 20 pounds. Got a red coat with some white paws, tuxedo kind of style. He's pretty chill, but trying to get him all trained up. Doesn't jump, doesn't bark too much. What about you? How are you enjoying these warm? Did you have a couple of warm weeks here?
Yeah, it's been
pre-spring
60s the last week, I would say, and there's still snow on the ground. It just is pretty depressing that it still has not all melted yet. But It's great to see grass again. We've had sunshine. It's been great. Kids have been riding bikes, going on walks. Took them to a yoga class for Valentine's Day, which was fun to see them stretch and balance and meditate to a certain degree. But it's busy. We're in full high season of plastic surgery in the winter here, where while it's cold and dreary, everyone is making their bodies more fit. And some of those patients that we both treat are massive success stories because they're what is termed as massive weight loss patients. So either through bariatric surgery, gastric sleeves, gastric bypasses, or through more commonly, and I would say more recently discovered, these GLP-1s are taking over as far as Ozempic, Mounjaro, and allowing patients to safely and sustainably lose weight to a really high degree. So while we see mommies who want their makeovers done and maybe they've lost 15, 20 pounds of baby weight, Dan, how would you characterize massive weight loss patients? And then what are some key differences that sort of separate them as far as your direction and strategy as a board certified plastic surgeon approaching them to reach the goals that they want to achieve?
Yeah, so I mean, massive weight loss patients are very different than our traditional kind of common mommy makeovers, 2-3 pregnancies, whatever that might be. That general laxity, you need a tummy tuck, is different than when someone's lost 100 plus pounds. And we're seeing more and more of that, like you mentioned. And we've covered a lot of these topics in previous podcasts, but really wanted to kind of hammer in on some of the more advanced techniques to kind of help address the general laxity that can kind of happen everywhere in the body. That loose skin, as it kind of rapidly deflates, if someone's younger, sometimes it does snap back, but I'm seeing patients even in their 20s who have lost a substantial amount of weight and still have, all this loose skin. So age isn't always that big of a predictor. I think genetics plays a big role in how that skin recovers. And again, it's loose skin, not just in the abdomen. It's often, buttock laxity, drooping orthotics of the butt area, upper back, upper abdomen, arms, chest, obviously the breast and thighs as well, which you've talked about. This can be, lead to severe, confidence issues. They feel so much different, feel so much better, but then they have all this loose skin to deal with. You want to touch on some of kind of the functional issues that loose skin can lead to for these patients?
Yeah, and so these massive weight loss patients, which I would characterize as, certainly over 50 pounds, but we were seeing patients who've lost 100 pounds, 150 pounds. They are rewarded with their improved health and their better living off of medications with all of this loose skin that can cause rashes. It can be irritating. It's really hard to tuck it all in, and it can lead to lots of lost confidence and in their journey. And a lot of patients sort of see this as that carrot at the end, the reward for all of this hard work. It can lead to confidence issues. It can lead to intimacy issues. Really just basic daily living issues of clothing, of finding the right bra, the right pants, as that tissue is really just loose skin all over the place. So not specifically in the belly from somebody who's been pregnant, or maybe just genetically it's their arms or their thighs, but it's almost universally and uniformly across their extremities, their back, their belly, their upper back, their lower back, everywhere, as we're about to get into. So Dan, here's a rapid fire question. So patient comes in, they've lost 100 pounds, they have loose skin everywhere. Lipo is just going to fix that? You just do liposuction?
Yeah, no. Liposuction, like we've talked about many times, is great for contour. It does not address loose skin. So we often do use it as part of the contouring tool and to improve that final outcome, but it's not going to address that skin laxity. So how do you approach a patient that comes in after losing a ton of weight? They say, I want to, they call your coordinator in your office, they want a tummy tuck. How do you, approach that during the consultation when you see, laxity elsewhere?
Yeah, I first want them to establish their goals, to tell me what their priorities are. For some patients, they may focus on just their belly, or they might say, "Hey, I want this all done," and that quickly shifts to informing them that this is a strategy, and this is not just one battle, but a war that may take several stages, and so it's almost impossible to do all of the things at once, just from a safety and a healing profile. We've talked in previous episodes as far as trying to limit the length of surgeries to maybe 5 or 6 hours in order for them to be outpatient, but we also want them to heal well. These patients have a slightly increased risk of wound healing problems, of seromas or fluid collections, of potentially scarring. And so we want to make sure that their body has the nutrition, has the reservoirs in order to accomplish these tasks. So, first things first is, what don't you like, and how can we achieve that? Set realistic expectations to see, make sure that they're not trying to be, Sports Illustrated swimsuit cover, but just be appropriate in their clothing. And oftentimes we can give them a very aesthetically pleasing, satisfying refresh to their body, but just make sure that what we're envisioning is what they're envisioning in those areas, and then try to create a detailed plan as far as which body parts can be in combo. If you don't have anything else to add, or if you have any changes to that, I do want to ask you, because most patients really choose their belly and just say, "Hey, I want my stomach fixed. It's so loose. It's hanging over my belt." Do you offer these patients just a standard tummy tuck, or is there something more to it?
It's always about talking, like you said, about expectations and what their concerns are. So it's not uncommon that someone's lost a lot of weight, and again, depending on where that skin fold is, the skin laxity is, sometimes a tummy tuck can provide a nice aesthetic outcome for the front. But I routinely will point out, depending on where that goes, like, well, this will be tight here, but it's not unusual for them to be bothered by the laxity in the buttock area. So we can, routinely either take that longer. The extended tummy tuck, there's different kind of version of this. I tend to use that, or kind of think patients need that when that skin fold extends further laterally, versus doing a circumferential tummy tuck or a torsoplasty where we lift up the buttock as well, kind of going all the way around. Again, this kind of is addressing two different areas: the loose skin in the front, and in the back, it's really lifting up the butt to kind of get rid of that droopiness or laxity in the lower back. So again, it's important to kind of talk to patients when if you're just doing a tummy tuck, it's not going to tighten the sides so much, because that's where you taper it off. The extended tightens the sides a little bit more. The full will lift up the outer thighs, lift up the butt, and kind of rejuvenate the whole lower kind of waistline area.
If that lower body lift or circumferential tummy tuck, however, the terms you want to say, is that going to give them a full butt, or are there other options to try to further rejuvenate a lot of the volume loss that we've said is everywhere, but includes their butt? And they're saying, hey, I want a butt. I want my butt back.
Yeah, so typically it can increase the risk of flattening of the buttock if you just lift up, because if there's not a lot of volume there, it's not going to create volume by itself. So there's two real options that I tend to recommend patients. We can do fat grafting if they have adequate fat to liposuction. Sometimes patients have lost so much weight, there's not a lot to liposuction. Or we can do something called autogluteal augmentation, where you, instead of removing the skin and fat, you just take off the skin part and leave that fat that's kind of below, lift up the skin and kind of elevate it up and rotate that fat down. So it's kind of utilizing as much of the volume they still have there and kind of repurposing it, but leaving it attached. That can be a really nice option. Again, a lot of it depends on their anatomy, their goals. So it's all about talking about those different options.
Do your incisions change for a man versus a woman if you're designing that butt incision as far as straight line or curves and so forth?
Males, we try to keep it a little bit straighter, kind of sharper. We tend to wear, lower underwear lines. Females, we try to make it a little bit more of an arch, kind of like a, bikini thong kind of line in the back area. In the front, trying to, a little bit more of an angulation versus males more straight. Do you have a similar approach?
Yeah, exactly. And as we are big proponents of drainless surgeries, does this circumferential or incision all the way around the body to try to lift the lower body, potentially accentuate the butt and get rid of a lot of that lower back, lower belly laxity, does that require you to place drains, or are you still doing that in a drainless fashion?
I'm typically still using that in a drainless fashion. In some situations, if someone's BMI is still higher in the 30 range, which I tend to think they're going to get a better result if they can get it lower, but 30, 33, then I might say I might put a drain in, depending on how much liposuction we do, but it's probably less than 5%. That's probably even a high estimate. I really try to avoid drains as much as we can.
And then as far as
your same approach.
Yeah, 100%. I really try not to use drains. I feel like sometimes that creates more fluid, and just obliterating that space, tightening it up has been the way to go. So I agree, maybe if it's a high BMI. And similarly, we worry about other issues such as DVTs, blood clots. I'm a proponent of early ambulation, getting patients up, moving around. Do any of these procedures require anticoagulation, Lovenox, blood thinning medications in your practice?
Again, it's kind of looking at the whole patient. So length of surgery, their health history, their family history. So we take make a score, a Caprini score, kind of before surgery to see if they're at a higher risk factor. So I don't give routine anticoagulation after surgery. A lot of it's early ambulation, compression devices during surgery, kind of my main focus, and trying to avoid blood thinners that could also increase the risk of bleeding issues afterwards. Looking at the other vectors of skin laxity, you want to talk a little bit about what we just discussed is really pulling down and lifting up, kind of that vertical direction. What do you do if someone comes in if they have a lot of laxity elsewhere, kind of horizontally? Do you approach that differently?
Often these massive weight loss patients 50 pounds or more have lost weight. There's laxity in every vector or direction. So a lot of times as I'm examining them, and I usually apologize ahead of time, I don't mean to, rough them up or anything, but I'm just trying to visualize where this tissue can go, what that final result's going to be. And if I'm pulling it down, the loose abdominal tissue towards their feet, and I'm lifting their lower body up, and there's still a lot of laxity in that side to side direction, then oftentimes we incorporate what's called a fleur-de-lis abdominoplasty, and that is just the term for that upside down T incision in order to address a lot of the two vector laxity that exists. So by just pulling it down, you're still going to have some laxity in that side to side. By making an incision that's pretty much either between their breasts or at the base of their sternum or xiphoid, all the way down, and it goes through where the belly button is, and it then tees off or connects to that transverse incision. That allows us to really tighten the waistline, remove a lot of laxity, and really present that tiny person that's hiding behind all of that loose skin and fat in both directions. And so I have used that and incorporated that in just a anterior or front abdominoplasty. And I've done that also in the lower body lift or circumferential, where we're able to maintain the blood supply, pull things together, tighten it up, and it can be quite a dramatic result on the table. And those patients are usually interested in seeing the intraoperative photos and the weight of the tissue that's removed. And those are also patients that tend to do in a drainless fashion, incorporating postoperative compression garments, postoperative lymphatic massages, optimizing nutrition, really trying to meet the patients at their level to reach goals and put all the odds in our favor to have an excellent outcome and result.
Yeah, the fleur-de-lis is a very powerful surgery, and I do the same thing. I kind of pull down and I say, well, there's still this kind of horizontal laxity up top that could be an issue after surgery if we don't address that with that vertical incision. And then the last often overlooked subunit is kind of the upper back, kind of that can extend to the upper abdomen. Again, in some scenarios, patients arrive and they kind of have almost multiple layers of kind of rolls or loose skin kind of coming off the lateral chest and the lower abdomen area. What are your thoughts on kind of approaching those?
Yeah, it's important to point those out and to address what rolls or, sort of those waves of loose skin and fat can be addressed with what the lower body lift will do, what the fleur-de-lis would do. Oftentimes there is just a clear discussion about, like, we need to separate or stage these. We can't have two things pulling in opposite directions. And so, oftentimes I have them kind of prioritize what their biggest concerns are, but incorporating what's called a bra line lift in my practice has been a wonderful addition, in which we're hiding the scar that's going across the back in a transverse fashion, typically where the bra sits, and that addresses a lot of the upper back skin and fat. It's oftentimes combined with liposuction. Is really able to contour those areas that are hard to reach with just what the lower body lift or even the fleur-de-lis would do. I oftentimes have to turn them over and sort of finish that as it extends towards the breast for these massive weight loss patients, to try to avoid any bunching up or fullness that still resides in that area between the breast and the back. There is also another trick up our sleeves as board certified plastic surgeons, in which you can try to address some of that laxity in the back with a tummy tuck or with the anterior incisions. Dan, what's the option that I'm leading you into discussing?
Yeah, so again, it's not all too common a technique, but again, in the right patient, it can be really powerful. There's different terms for it, but often kind of for like an open book. So imagine kind of opening a book and closing it. It's combining, that T incision we just referred to, the fleur-de-lis, with that upper back kind of reverse tummy tuck. So these different subunits are often caused by kind of these tethering underlying bands that, if they aren't released, aren't going to redrape properly. And if they're all the way up by the upper chest, you can't release all that and pull it all down. So the upper back, the open book technique literally combines that bra line lift, wrapping around underneath the breast to that T incision. And then again, with the T, you're not pulling down quite as much because you're now lifting up above, but leaving, again, we talk about the importance of blood supply in terms of things healing. You're leaving a lot of that central connections. You're not undermining nearly as much as a traditional tummy tuck to, lift up, pull down in the front as well. So again, it's not a super common way of addressing things, but for the right patient, it's super powerful to kind of address, all of that. Because sometimes it can be really kind of devastating to just get the lower area, but be left with, the really extreme upper laxity. But it's, again, talking to the patient about what their priorities are. We can only do so much surgery at one time. But if the length of surgery is, reasonable, safe, they're healthy, they're in good health, good nutritional status, you can, I think, very safely do this, again, in a drainless fashion, addressing a lot of different areas at once to really try to smooth everything out. And one thing I think is always, sometimes patients come in after surgery and they say, "Doctor, there's still loose skin when I'm sitting down." What do you tell patients about that?
Yeah, I mean, the human body's pretty amazing. We want to make them snatched and as tight as possible. But, I always jokingly say that plastic surgery is the constant battle between beauty and blood supply. And so you had mentioned not undermining or not, having to tug or pull as much for some of those open book tummy tucks. And, really part of it is what you were mentioning casually, is that you care about the blood supply. You want to make sure everything lives and survives, in addition to just undermining and pulling it all together, because we need to make sure that the tissue survives. In the same way, we can make things tight and it's quite snug on the table. I promise them that we made it very tight in a healthy way. But over time, naturally, the tissues stretch and there's elasticity. I always tell them about the phases of healing. 3 to 8 weeks, there's going to be peak swelling and scar tissue. The body then realizes it's overdone it and switches to a remodeling phase. And pretty much at 1 year, if anybody bends over to tie their shoes or something, they're going to have a little pinch of skin. If they were to say, I have all the money in the world, all the recovery time in the world, take it out, and I were to take out that pinch in another year, they would still have some laxity that's there. And that's just the way the human body responds to stretch and motion and tissues. And what we want to balance is wound healing problems, fluid collections, widening of scars, the tension that we're setting, and allowing the results to be appropriate for their body type and for their expectations. Do you have anything to add to that commentary? Because I have a couple questions for you.
Yeah, I think, again, I might have a little shorter answer to my patients, but routinely I say we pull you as tight as we can on the table, but you also need to be able to stand up again. And like you mentioned, our bodies are adaptable. So we pull things really tight and our body is the scars are going to relax. The leftover skin is going to relax to allow you to move and twist, stand and bend, all very important things. So we want to make sure things heal well, that you look great. But sitting up, it's impossible to not have a little bit of that laxity present, despite all our best efforts.
One add-on or complementary procedure that these wonderful patients, brave, have gotten through hard work to get the results that they want, are a little bit timid to mention, but is very important, and something that's really on our radar, is the Mons area. So that area of kind of loose skin laxity that's just over the pubic bone that sits down there, and they're all we're worried about it. They're worried about it. How do you address that? What's your approach? What do you tell them about that specific area? Is it included? Is it going to stay there? Are you leaving it alone? What do you do with that? Oftentimes trouble spot for the patients who've lost lots of weight.
Yeah. So that Mons pexy, personally, I think it's just part of the tummy tuck. So I've had patients come in, so, they wanted to charge me extra to lift the Mons. I'm like, I don't really understand that. It's all about placing that scar, and planning that to end up in the right spot. So during the marking phase, we're really lifting that up quite tight, kind of trying to position and then placing that incision, normally 6 centimeters kind of above that cleft area, to try to keep that scar super low, easy to conceal. If you put the scar kind of in where the skin fold is, it often ends up way too high, and then you're left with all that lower laxity. So super critical area, super important part of that planning phase, to get a very lifted and nice improvement in that Mons area, which is often a very concerning area for patients.
Yeah, I just had a patient today who's great gastric sleeve, lost a lot of weight. And, one of her last questions was, what about the Mons? And she's like, I don't see it on the consent form, or, are you not doing it? I'm like, well, I don't typically put that on the consent. It's part of my tummy tuck, part of the tummy tuck charge or fee. I'm not going to be saying I'll do a tummy tuck without it. Right. It is part of the time that's spent, and it's part of the measurements, and, making sure the hairline is not being pulled up too much and the incision's at the appropriate spot. But it does take some extra time in these specific areas.
So that's these massive weight loss patients are often, it's incredible transformations. It's really I'm always thrilled to kind of be a part of their journey. You want to talk about the arms too? Yeah. There's another area that often is we often talk about arm lifts, where the scar goes elbow to armpit crease, but like we talk about that upper back area, there's horizontal laxity in the abdomen. There's also horizontal laxity there as well. How do you like to chase that incision down?
That was a cool thumbs up you did. So yeah, it's really trying to make a roadmap to create tension-free closures. And what I tell them for patients who want to undergo the brachioplasty is that incision could be extended in both directions. So in a traditional arm lift, it stops at the elbow to try to make the scar as inconspicuous as possible. But these patients grab their forearms and say, what about all this stuff? I want this gone too. And then I have a frank discussion of that scar will be very visible. If you'd rather replace the laxity with the scar, which oftentimes they do, I'm quite comfortable with extending it below the elbow so that there's not any dog ears or any bunching up of that laxity, or leaving them with a very tight upper arm and a very loose lower arm. That just in and of itself is not a normal aesthetic result. And then if that laxity really extends beyond the armpit, we can chase that, or we can follow that down, kind of like the seam of your clothing, where we can go to the armpit. Oftentimes I make a little Z or a little V to not have there be any webbing for that scar. And that's the area where we can pinch and tighten and close that laxity that exists between the breasts, which is sometimes hard to do with the breast augmentation lift procedures, and the broadline lift, where sometimes in that vector of going across the upper back, we sometimes can't get that vertical laxity too. So that's where that extended brachioplasty or up and down incision along the side of the body can be quite helpful in those specific cases. So tend to be pretty fun. And
you can actually take that incision. Yeah, you can actually take the incision all the way down. I tend to think that upper back lift is a better vector for pulling, but in certain, I think a couple times I have, when patients kind of just have this little bit of laxity, want to avoid the central scar. Instead of pulling it this direction, you kind of pull it both on sides like the seam of a shirt. So lots of different ways of you can pull the skin. It's all about again evaluating the patient fully, seeing where all their skin drapes, what their concerns are. And doing this in a safe manner. And like we mentioned, a lot of these do require stages to address all the skin and all the different layers and vectors that we're kind of trying to focus on.
Yeah, it's almost like operating on Stretch Armstrong in some cases, where they're like, well, can't you pull this and go further down? I'm like, yeah, but now I'm pulling your breast to the side, or I'm pulling your back to the, to your front. And, at some points we just need to address these in different stages. It's different types of procedures dedicated to those body parts. And they understand that. And I really love the fact that, there can be stages, because, oftentimes we can, sometimes tidy up or refresh, some of the old procedures during the next stage, oftentimes, free of charge, but just to make sure that they're very happy and elated with their journey, with their new body, with their restored confidence, fitting in better clothes. Sometimes they say they haven't seen their toes in quite some time, or they're able to, put a belt on and, not have it, slide off. And so these are just really satisfying procedures to do in patients who are elated to be, reaching the end of their weight loss journey. And it's important for them to find board certified plastic surgeons focusing on breast and body who do this and have the experience and the, it's almost like a game of chess, have the strategies to see the multiple steps.
It's always kind of frustrating when I see patients come in who went, to a typical general surgeon, someone else just do a simple kind of paniculectomy, and it's just doesn't tend to really address the complexity of what's all going on. They're often left with things still not fitting well, not liking how things look, and it's quite rewarding in general, to see these patients afterwards and seeing their before weight loss photos to weight loss to then their final result. Just how their confidence kind of shines through in their faces and smiles. So, I think that was a great topic. A patient kind of suggested that she wanted to kind of hear more information about. So we always appreciate that feedback. If you have any other great ideas, just let us know. We'll keep on pumping these out.
Enjoy your new puppy.
Yeah, thanks. We'll chat soon.
All right, take it easy.
Yeah.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButzMD. That's Butz with a Z, for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.